Hello and welcome. Today we're diving deep into a really critical topic, perioperative antimicrobial prophylaxis, focusing specifically on orthopedic surgery. We're going to break down the strategies for preventing infections in some of the highest risk procedures out there. So, let's get right into it.
Here's our roadmap. We'll kick things off with the basics of surgical infections, then get into the nitty-gritty of identifying pathogens. From there, we'll look at the actual treatment regimens, cover some key prevention tactics, talk about what to do when an infection does take hold, and then wrap it all up with a real-world case study.
So, first things first. Why all this focus on prophylaxis? Well, it all boils down to one simple but powerful idea: stopping an infection before it even has a prayer of starting.
See, prophylaxis isn't about treating an infection. It's about preventing one. The whole game is about getting a solid concentration of antibiotic into the surgical tissues before that first cut is ever made. You could think of it like setting up a defensive shield before the enemy even shows up. This gives you a crucial window where bacteria just can't get a foothold and start to multiply.
But of course, prevention is just one side of the coin. When you do suspect an infection, or you're dealing with a super high-risk situation, that's when diagnostics become the absolute bedrock of your entire response. And that means being really rigorous about how you identify what you're up against.
And what's so fascinating here is just how meticulous you have to be with these cultures. This isn't a simple swab test. For a contaminated open fracture, you're taking cultures right then and there. Suspect a spinal implant infection? The protocol calls for 4 separate deep cultures. And for a prosthetic joint infection, or PJI, you need 5 to 6 different tissue samples. And look at that incubation time, up to 2 weeks. That's essential for catching those slow-growing bugs. And this last point, sonication, it's brilliant. It uses sound waves to literally shake microbes loose from the biofilm on an implant, which massively boosts our chances of figuring out what we're fighting.
All right, so with that diagnostic groundwork laid, let's get to the protocols themselves. What drugs are we actually using? And, just as importantly, when are we using them?
You know, when it comes to prophylaxis, timing is literally everything. That goal we just talked about, having that protective shield up at the moment of incision, it completely depends on getting the timing right. The key is that the full dose has to be in the patient before the surgeon makes that first cut. For a standard antibiotic like Cefazolin, that means starting the IV within the 60-minute window before surgery. For other drugs that infuse more slowly, like Vancomycin, you need to give yourself more time, up to 120 minutes.
For big joint replacements, think hips and knees, this is pretty much the standard playbook. Cefazolin is the go-to, given as that single pre-op dose. But what happens if it's a really complex surgery that goes on for a while? Well, the protocol is clear. If the surgery lasts more than 4 hours, or if there's major blood loss, we're talking over 1,500 milliliters, you give a second dose right there in the OR to keep that protective level up. And of course, if someone has a penicillin allergy, we've got solid alternatives like clindamycin or vancomycin.
Now, things change a bit for fracture and spinal surgeries. For those nasty open fractures, Cefazolin is still the top choice, targeting the usual suspects like Staph aureus. For a standard spine operation, 1 pre-op dose of Cefazolin is usually enough. But again, if the surgery drags on for more than 8 hours, you extend that coverage out to 24 hours. And here's a really sharp clinical pearl. If the surgery goes through a potentially contaminated area, like the mouth, you broaden the coverage. You use Cefazolin plus metronidazole to make sure you're covered against anaerobic bacteria too.
Okay, so beyond what we do in the operating room, there are some incredibly powerful things we can do to lower the risk before the patient even gets there. Let's zoom in on one of the biggest game changers.
So let me ask you this. How can we tackle one of the single biggest patient-specific risks for infection? Well, it turns out many of us, completely unknowingly, carry Staphylococcus aureus in our noses, and that bug is a leading cause of these infections. The answer, then, is surprisingly simple.
Just take a moment to really let that sink in. A simple nasal swab to screen for the bacteria, and then a straightforward treatment for those who are carriers can slash their risk of a serious surgical infection. It's an incredible payoff for such a simple intervention. 60%. That's not a small number. We're talking about potentially preventing more than half of these S. aureus infections just by identifying and treating nasal carriers with a little intranasal mupirocin before their surgery. It's a huge win for patient safety.
But what happens when, Even with all our best efforts, an infection does set in. Well, at that point, the entire game plan has to change. We're no longer in prevention mode.
This slide lays out the difference perfectly. Think of it this way. Prophylaxis is proactive. It's 1 or 2 doses, timed before surgery, aimed at likely bacteria. Treatment, on the other hand, is completely reactive. The goal isn't prevention anymore, it's eradication. This means a long, targeted course of antibiotics to kill a confirmed pathogen, and it almost always involves more surgery. They're just 2 fundamentally different worlds.
And when you're treating something like a prosthetic joint infection, a PJI, it's a massive undertaking. First off, it's a team sport. You need surgeons, infectious disease docs, microbiologists, everyone. Therapy kicks off with high-dose IV antibiotics. Then, if things are looking good, maybe you can switch to oral meds after a week or so. But just look at that duration. We're talking 6 to 12 weeks of treatment for an acute PJI. And if the infected implant can't come out, that patient could be looking at suppressive antibiotics for 2 years, or even for life.
Okay, let's pull all of this together now and see how it plays out in the real world. We're going to walk through a quick case study of an infected spinal implant.
So, imagine this scenario. A patient who recently had spinal hardware put in comes to you with clear signs of an acute infection. The clock is ticking, and you need a systematic, aggressive plan.
The workup needs to be fast and thorough. Step 1, you run labs. You're looking at inflammatory markers like CRP and SED rate, plus a CBC. Step 2, you're getting cultures immediately. Blood cultures, and if you can, a direct fluid sample from the surgical site. Step 3 is imaging, an MRI or CT to see just how bad it is. And then step 4, the most important part. You get them to the OR for surgical debridement, ideally within 24 hours, to clean everything out.
So after the debridement, while you're waiting on those culture results, you start what's called empirical therapy. And this is the recommended cocktail. You've got flucloxacillin on a continuous IV drip to hammer any staph bacteria. You add oral rifampicin because it's fantastic at getting into biofilms, and then you have gentamicin for broader coverage. But, and this is a really nice bit of clinical thinking, if the gram stain from the OR already shows you've got gram-positive bugs, you can hold off on the gentamicin and spare the patient potential toxicity.
Which brings us to our final thought for today. We've gone over the current best practices, but of course, the microbial world doesn't stand still. Bacteria are always evolving, resistance is a growing threat, and biofilms are a constant challenge. So the real question we have to leave with is this. As the enemy changes, how do we make sure our strategies, both for prevention and for treatment, change right along with them to stay effective? It's a question that's going to shape the future of this field. Thanks for joining me.